Dan Hansen with DHA Laboratory. Thanks for coming today. I'm super excited to announce our speaker, someone I've known, worked with, and respected greatly for over a decade, Dr. Heather Sandison. Dr. Sandison is a physician specializing in neurocognitive medicine. She spent her career doing what most in the field said couldn't be done, helping people slow and in many cases reverse cognitive decline. She's the founder of Solcier Health Clinic in San Diego, California, and Marima, the first residential memory care facility built around the goal of returning residents to independent living rather than simply managing their decline. Dr. Sandison is also the primary author of a peer-reviewed research publication demonstrating measurable cognitive improvement through personalized lifestyle intervention, which was published in the Journal of Alzheimer's Disease. In her book, Reversing Alzheimer's, the new toolkit to improve cognitive and protect brain health, was an instant New York Times bestseller. On a personal note, I've known Heather for more than 10 years, and DHA has had the privilege and pleasure of supporting lab work for her clinic and her patients throughout that entire time. Watching what she's built and the outcomes she's delivering for families who've been told there was no hope is genuinely inspiring. This is Heather's second webinar with DHA, and we're thrilled to have her back. Dr. Sandison, the floor is yours.
Thank you, Dan, so much for the warm introduction. It's a privilege to be here today. I wanted to first share the objectives that I have for this conversation. So one, I want to go through some of the current research, and there's some really exciting updates to this. In fact, just this week, there was a Cochrane review that was out, and I can't wait to kind of share with you how I'm thinking through this and how my colleagues and mentors are. Also, we want to talk about common causes and kind of this paradigm shift around what we think are the drivers of neuropathophysiology, of neurodegenerative disease, Alzheimer's in particular. Then we'll go through some workup and then treatment options and how to track changes over time so that you can feel armed to hit the ground running when you go back into clinical practice. So this notion that Alzheimer's is reversible, this is a bold claim. And the narrative is absolutely shifting. There's no doubt about that. And yet, I think that there's still those naysayers out there who are like, how do you know that that's true, that you can do that? I thought Alzheimer's was just a one-way street. That's what the neurologist who, this is their area of expertise, that's what they say. So how do we know? How do I know that this is reversible? Well, one, I've seen it, not just once, but over and over and over again. We've seen this. In fact, today in my clinic, I just saw on Slack, there was a message that came out that we had a patient go from a MoCA of 3 to 7 in 90 days. And these single-digit MoCA scores, they are much harder to turn around. But I mean, we just saw this today. Something that we thought was impossible is happening regularly in our clinical practice, in our coaching programs, and amongst my colleagues also in their clinical practices. The other thing that helps me rest in like this certainty that this is possible is that we've measured it. And I've published that in the peer-reviewed literature in the Journal of Alzheimer's Disease in June of 2023. We published that, and I'll go through how we designed that study and what the outcomes were. But I'm not the only one who has researched this and published this in the peer-reviewed literature. This has been corroborated. We see this over and over again. We can predictably get improvements in cognitive function when we apply this model that I'm going to present today. So one of the first times I realized that this was even possible, that we could reverse cognitive decline, was when I saw Arlene. So she came into my office in the fall of 2017, right after I had been trained by Dr. Bredesen. And as his book, The End of Alzheimer's, had come out, there was a lot of traction around that. And I had patients coming into my office with way more confidence than I had that I could treat them. But I went through the motions with Arlene. Her and her husband were there. She was entirely, completely dependent on her husband. I could see that she could you could see the wheels in her head turning as I would ask a question, but the only thing she had for answers was yes or no. She couldn't formulate a full sentence. Her handwriting was really, really cramped. And yet I could see her soul sort of shining through, right? She had this big smile, and she had this floral print dress and this black, like leather studded bag. And her husband was talking about how she loved to play dress up at home, and like she just loved her closet and all of her clothes. And you could just see that there was this human in there, like her soul was still there. And we just needed to like tap into it. I didn't think I could help them. I really didn't think when they walked out the door that they would come back or that we would see any improvement. But they came back 6 weeks later to review labs, and I had sent them on their way with supplement recommendations and, of course, lab testing. We had talked about her getting her dental work done. They knew they were living in a moldy bedroom, and they moved out of that bedroom into their living room. They started ballroom dancing, walking, they got into ketosis. She started on bioidentical hormone replacement. And 6 weeks later, her mocha had gone from a 2 out of 30 is quite severe. So 26 and above is normal. It's a 30-point test. And she had a mocha of 2 the first time we saw her and a mocha of 7 the second time. And my first thought was that we had done something wrong, that we had somehow done the mocha wrong. And I looked at her husband just in disbelief, like, wait, what? Is this true? Like, really? He's like, yeah, things are different. She's putting together complete sentences. I always tell people they were bickering about something that had happened on their way into the clinic. And their relationship had changed, right? It had transformed. She was able to communicate her needs, her wants, her experience. It was not only different for her, but of course for her husband. And we see this that Alzheimer's it's not a disease that only affects the patient, it affects their entire ecosystem, everyone who loves them. And so that moment I saw Arlene's improved MoCA score, it was just this a really emotional moment for me where I was like, I can't do anything else with my life but tell people this is possible. I mean, how much suffering is happening unnecessarily? And so the goal today is to make sure more providers really understand how to deliver this care because it is absolutely possible. So this is an illustration of how much benefit we're getting from this multifactorial intervention. And this comes from a paper that was published by Dr. Bredesen, Kat Toops, the crew at Apollo Health. This was in July of 2022 in the Journal of Alzheimer's Disease. They published this data. And what this is basically showing is changes in cognitive scores. So I talked about the MoCA, 30 out of 30 is perfect, 26 and above is normal. And what we expect is about a 3-point decline per 12 months for someone who has cognitive decline, right? Who's in those MoCA scores under 26. So what we see with RECODE, which is the Apollo program, Dr. Bredesen's approach, essentially this naturopathic functional medicine approach to cognitive impairment, what we see is an average of a 3-point improvement over 12 months. And I think many of you are aware of donanemab, lecanemab, also known as Kisunla, and Leqembi, and then Aduhelm or aducanumab, which has been taken off the market. These are those antibody therapies. And we knew even back in 2022 that those antibody therapies do not get improvements in cognition. What they get in the best case scenario is a reduction in the rate of decline by about 30%. In men, in women, it's closer to 10%. And then no treatment, what we're expecting is a 3-point decline. So the delta here is about 6. We're not only are we slowing down the decline, but we're seeing improvements in cognition repeatably. Like, this is happening predictably. And with those expensive antibody therapies that have the risk, of course, of brain swelling and brain bleeding, we see a slowing in the rate of decline, not improvement. So my clinical trial, this was published in the Journal of Alzheimer's Disease in June of 2023. We had 23 participants, very similar study to the outcomes I was just showing you with that average of a 3-point increase. Our clinical trial was 23 participants. Theirs was 25. We had an eligibility score. The MoCAs were 12 to 23. So this is moderate, not just mild cognitive impairment, but even going to moderate. We did not exclude people with an Alzheimer's diagnosis. We included them. And then we had a 6-month intervention. So in Dr. Bredesen's trial, they had 25 participants. They had an eligibility criteria of MoCAs down to 18, so not as progressed. And then they had a 9-month intervention. And they saw that 84% of their participants improved. And we saw that 74% of our participants improved. Now we had a shorter intervention and we had more progressed patients. So it makes sense, right? We're corroborating what he said. We're basically clarifying that, like, yes, this is in fact, we're picking up a signal here, even though these these trials are small, we in our case, we get p-values, right? We have statistically significant improvements in MoCA scores, in overall composite cognition, in memory specifically, in quality of life, and in sleep scores as well. So that's the mean across all participants. There was improvement in all of those factors. So the side effect of this is that quality of life improves, sleep improves. We often see that people's blood pressure improves, that their mood improves, that their sleep, of course, improves, that their diabetes resolves. So this is a really fun thing to present to patients. It takes work, but it's possible. And so this trial was published by Dean Ornish. Many of you have heard of him. He's kind of he's famous for cardiovascular interventions. He's up at UCSF. Or has been. So he basically took his cardiovascular intervention and used it for mild cognitive impairment and early dementia. This was a 20-week trial. So this was a 4-month trial, so even shorter than my trial. And it was, there were 51 patients, so it was a little bit bigger, and they did do a control group. So this was the first controlled trial. And after 20 weeks of a very similar lifestyle intervention with some coaching, exercise, diet, the diet they used was we use ketogenic diet. Dr. Ornish uses a vegan diet, but essentially both of them were reducing not carbohydrates in the Ornish trial, but complex, basically the highly processed foods. Excuse me. So we're getting rid of highly processed foods and improving the diet, especially compared to a standard American diet. And they also used some supplementation. So they got the nutrients up. So similar trial, different, but similar. Multifactorial lifestyle intervention essentially is what this was. And they saw that there was across the means of their participants after 20 weeks, there was improvement in cognition. So really exciting stuff, right? This is consistent. We're seeing this. Even though they're small trials, we're getting statistically significant changes in these outcomes. And it's not a slowing of the rate of decline. It's improvement in cognition. It's not focused on amyloid. It's improvement in cognition. So, and that's where the rubber meets the road. Like that's what patients want. That we don't care about our amyloid numbers. We care if we can have a relationship with our loved ones. We care if we can remember birthdays. So this is one of the newer papers that has come out that's had an impact in in my world, the dementia world, and this is the Pointer trial. So this was funded by the Alzheimer's Association. This is a structured versus self-guided. So it's structured coaching on lifestyle interventions versus a self-guided. So they had information only, was the control group. Over 2,000 patients, so 2,100 patients were enrolled, and then it's a randomized controlled trial. It was completed over 2 years, and lo and behold, they saw that people who were involved in these lifestyle interventions aimed at improving cognitive function, they got better. They all got better. The more structured group got more better. So these are improvements in cognitive function when we take a multifactorial lifestyle approach to this disease process. This is the paper that just came out this week, April 16th of 2026. And this is, I have so many mixed emotions because this is about the amyloid beta monoclonal antibodies. So the ones that I mentioned before that slow the rate of decline by about 10 to 30%, depending on your sex and which one you use. And so much money, time, effort, bandwidth, taxpayer dollars, smart people's time has gone into these monoclonal antibody therapies. They are very good at getting rid of amyloid. But fundamentally, at the end of the day, amyloid doesn't matter. Cognitive function matters. So the author's conclusions here, successful removal of amyloid from the brain does not seem to be associated with clinically meaningful effects in people with mild cognitive impairment or mild dementia due to Alzheimer's disease. Future research on disease-modifying treatments for Alzheimer's disease should focus on other mechanisms of action. That's what we're here to talk about today, other mechanisms of action, because they don't work. It's so sad. I wish that they did, because the suffering associated with this disease is profound. It's horrible. And we need a solution. So let's talk about what it is. All right. So if you have, it's a paradigm shift. If you have a house plant in your house and it looks like this, what do you think when you look at that house plant? Do you think to yourself, oh, we should take out the amyloid? There's misfolded proteins. Let's get after them. No, you think to yourself, does it have enough light? Is it getting enough water? Does it need fertilizer? Is something poisoning it? Right? You think about the things that allow a complex organism to thrive. And so that's what we want to do when we think about the brain. It's common sense, but it's uncommon practice, right? It's so frustrating because we need we need to think about the causes of all diseases in this complex system science approach, right? We need to be thinking about what are all the inputs and all the outputs that can start to feel overwhelming, but we can systematize that approach. And the way that I would offer, like the way I create the framework I create in my head so I can stay organized and not feel overwhelmed by the complexity of this, is to think about it as balance, right? So, or imbalance as causing disease. And when we have an imbalance in a complex system, whether it's a financial system, an ecosystem, an education system, a government system, or the brain or the body, imbalance is going to cause dysregulation and dysfunction, and in this case, a neurodegenerative process. So let's define that. What does imbalance mean? Too much, too little, in the wrong place, or at the wrong time. If we can start to systematically correct for this throughout the body, throughout the brain, we're going to get better cellular function. It's just inherent in how the system works, right? So how do we identify these and where do we start? Well, the chronic diseases are all caused by, I would argue, including Alzheimer's disease and all of the neuropathophysiologies, all of the neurodegenerative diseases, they're caused by a finite number of things. So some people will say, well, Alzheimer's is caused by amyloid. No, amyloid is a downstream effect. Amyloid is triggered as a response to protect the brain from toxins, from infections, from microglial activation is what triggers amyloid, the amyloid cascade. It's part of our immune system. People in the functional medicine space will sometimes say Alzheimer's is caused by inflammation. What caused the inflammation? That's where we want to play. We want to be going upstream. And so I would argue that these categories are those things that are upstream, that are causal level. These are primary causes. And when we correct the imbalances here, we get better neuronal function. So number one, toxins, nutrient imbalances, structure. And so toxins, I'm hesitating because I want to jump into the labs and we have so much to discuss today. So I'm going to have DHA have me back and we'll dive into each of these in a lot more detail, but I want to give you an overview so that then when we get to the labs, we can structure this, we can organize ourselves so that we know kind of what gaps we might have in our understanding of the patient in front of us. So toxic exposures, mycotoxins, metals, chemicals, you know the drill. Nutrient imbalances, it's our macros. Diabetes is too much sugar. That can be an issue, but we can also have too little B12, too little magnesium. We can have micro and macronutrients out of balance. Structure, again, micro and macro. We've got our genetic risk, our molecular structure is our microstructure. And so ApoE4 status is important to understand here, ApoE status. And then also our macrostructure, right? Can we get air into our lungs at night or do we have obstructive sleep apnea? Can we get blood flow in and out of the brain? Is our neck crooked? Are we in chronic pain that's creating cortisol that's leading to a signaling to the brain that we're under threat that can become toxic to the hippocampus, that cortisol? And then stress, right? Stress, again, too much, too little. If we don't have enough, we need purpose and meaning. We need things to show up for, a reason to live. But if we have too much stress and it's keeping us from sleeping or it's keeping us from engaging in life in a meaningful way, that is going to be detrimental. Infections. There's a handful of infections that are directly tied to amyloid production, including HSV1, herpes simplex virus, P. gingivalis, what causes gingivitis, shingles, also COVID, Lyme spirochetes. So there's a handful of these that we know directly cause an amyloid cascade process. And then signaling. We need signals going into the brain that say connect, repair, regenerate. If the signals going to the brain are saying attack, defend, we're going to get microglial activation, and that's going to lead to that inflammatory process, right? So what we are trying to do is evaluate each patient through our history, our findings on our engagement, our first initial call with them or consult with them, and then also through the lab work. So, what can you do to protect your brain health? I would be remiss if I did not say this. What can we all do to be protecting our brain health, and what can we be talking to our patients about? Diet, right? A diet is important. Lifestyle medicine is important here. We're going to dive into the labs, and they are super, super important. But if you have a patient who can get on a ketogenic diet, get their metabolic flexibility, get their metabolism under control, get their fasting insulin under 10, their A1C around 5.3, 5.4, get their fasting glucose under 90, that is going to be someone who is at lower risk for dementia. Exercise. We have to move. And one of the best ways to get exercise to support our brain is racket sports, dancing, ballroom dancing, cued exercises like going to Pilates, yoga, Zumba, Tai Chi, Qigong, where we are engaging cognitively at the same time as physically. We've got to remember the steps in dancing. We've got hand-eye coordination and social engagement with racket sports. We're cued by an instructor, so we've got to pay attention and listen to what they're saying. The dual task exercise is by far you're going to get the most bang for your exercise buck if you are doing both at the same time, cognitively engaged and physically engaged. So we can talk to patients about these strategies. Sleep, at least 7 hours, and we're aiming for good high quality sleep, aggressively treating obstructive sleep apnea, and then also looking for that deep and REM sleep and enough of it. Stress management, again, is their purpose and meaning. Do they have some sort of stress management practice, whether it's a prayer practice, a meditation practice, a mindfulness practice, a gratitude practice? Understanding and managing our stressors is supremely important. Staying socially engaged is another big part of that. We are super agers, right? And everybody, this came out at Northwestern this year. And it also corroborates the Harvard research and other research that's out there. We are social creatures. And the people who have brains of 50-year-olds when they're in their 80s, they are people who stay cognitively engaged. They have a network of people, of other people around them that they regularly see who are peers, not just the people that work for them, their PT, OT, their doctor, their cleaning lady. No, they're people that they consider peers. That's really important. And then toxin avoidance, making sure that we're not allowing junk in that's going to put us in that attack and defend space, put the brain, the microglial activation is going to, that cascade is going to start if we have a lot of toxins coming in or more toxins coming in than we can get out. What we want to do is get those toxins out, free up resource so that our brain, again, can be in that connect, regenerate, repair mode. All right, I'm going to switch gears here and I'm going to share a sample report that and take you through how I interpret each of these pieces. So this is a patient a female over 65, and what we're looking for on this is kind of our kind of basic brain health profile. These are things that are going to be covered by insurance, easy to get through DHA. They are going to give us a really good sense of kind of baseline where this patient is. Now, there's lots more that we can do. If we're going to go deeper, we can. We can go into toxin testing. We can go into cortisol testing. We can go into infectious burden in different ways. But this is a great place to get started that no neurologist is going to do this for a patient, but we're going to get so many insights about what can be driving a disease process for this patient. So the first one here, adiponectin, this can give us a sense of metabolism at some level. This one is normal, and we're kind of triangulating. So we're looking at fasting insulin, we're looking at fasting glucose, we're looking at A1C. And through that, if we see things that are abnormal here, we're going to want to prioritize getting diet and exercise on board, maybe even consider GLP-1s if someone is overweight. There's right, there's an art and a science to this around what's going to be appropriate, but understanding someone's metabolism is a crucial component to knowing if their brain has enough fuel. Is there enough resource going into the brain? That it can repair and regenerate, right? That it can deal with toxins, the daily metabolic waste that's created. And ANA, this is our anti-nuclear antibody. This is giving us a sense if there is an autoimmune process going on. Again, that's going to take resource. If we have an overactive immune system, where resources are going to be pulled into fighting, and in this case, our self cells, instead of repairing and regenerating. There's going to be an attack going on, right? That attack and defend mode. And so one of the quick, easy things we can do here is a positive ANA. You can start with some LDN. I usually start with 1 milligram of LDN before bed. Now, if patients end up with diarrhea, it is not an option for them. I don't know a way around that. Maybe there's an expert out there who does, but if I have a patient who ends up with diarrhea, we just stop it. The goal in the terms of the dose is 4.5. LDN is usually dosed at 4.5, but I like to work people up, especially my patients over 65 who might be sensitive. And I watch out for that diarrhea. Also, we do it before bed. We dose it before bed because most people sleep a little bit better with it, and that can be helpful. If someone has a paradoxical response and they're more awake, then we just dose it in the morning. The other thing to think about that I've seen regularly with ANA improving is thymosin alpha 1, injectable TA1. So if that's available to you, then that would be something to consider as well. ApoA1 and B, this is lipids. Lipids, we could have an entire conversation about lipids, but essentially LDL is a risk factor. Elevated LDL is a risk factor for cognitive impairment, but also it's too much, too little. Too little total cholesterol is also a risk factor for cognitive impairment and all-cause mortality. So cholesterol is very much about a balance equation, and we want to we're on the same team as the cardiologist. I'm not saying no statins for anyone ever, but there are so many tools at our disposal between supplements and fiber, foods, exercise, diet, and yes, medications to manage cholesterol. And then I'll talk a little bit more about that as we get to the total cholesterol and our LDL, HDL. But ApoB is certainly, if anybody of you have heard anything from Peter Attia, he talks about ApoB being one of these primary risk factors to be paying attention to when it comes to cardiovascular risk. And then ApoE. So again, this is our genetic structure, molecular structure. And this particular patient is at risk. So if we take the entire population of the world, we have about a 13% chance of being diagnosed with dementia in our lifetime, regardless of genetics. Now, we each get 1 copy of ApoE from our mom and 1 copy from our dad. And this patient, we can't tell who they got it from, but got at least 1 ApoE4 from a parent. And this ApoE34 is somewhat common. ApoE33 is the most common. ApoE34 raises that risk from 13% to 30% chance of being diagnosed with dementia in your lifetime. Now, if you get 2 copies of ApoE4, 1 from mom, 1 from dad, that risk goes up to nearly 100%, certainly over 50% if you live past 65, excuse me. So this is, some people used to say to me, oh, why would I get that test done? Because it'll just keep me from sleeping. It's going to give me anxiety. That's going to increase my risk of cognitive impairment. I think that used to be the case. Now we know so much about what we can do to optimize cognitive function and protect our brain that I think, if someone comes back ApoE4 positive, 1 or 2 copies, and they have kids, they have grandkids, I want to know, because like for my child, I want to know so that if she is ApoE4 positive, I don't want her skateboarding. I don't want her big wave surfing or playing football or soccer, heading the ball in soccer, or working night shifts as an ER nurse or ER doctor. I don't want her binge drinking, right? There's these choices and priorities we can kind of make and career decisions we can make early on in our life, like right in our teens and 20s, that have an impact long term on our cognitive health. And so those, I think somebody asked me the other day, like, when should we start thinking about brain health? At what age? I'm like, in utero. There's never a time, like, it's never too early to be thinking about these things, in my opinion. It can be a little scary, but when you have so much information about what you can do, my hope is that it's empowering to patients. So hopefully that makes sense. Then amyloid ratios, so beta amyloid ratios and p-tau. I think I'm going to start scrolling up and down, sorry. But beta amyloid and p-tau, these, I think of them like our measuring stick. Where are we on the spectrum of cognitive impairment. And a MoCA score can help. We use CNS vital signs as well to give someone a number of where they are on this cognitive spectrum. You know, is it really early on? Is it only subjective and we're not even picking it up in the data, in the measurement, and the testing? Or is it mild cognitive impairment? Or are we getting towards more severe dementia? Now, beta amyloid and p-tau, these beta amyloid ratios and the p-tau numbers, unfortunately, they don't really give us that gradient, but they do tell us, they're supposed to, but they don't. Sorry to all the testing people out there, but we were told that p-tau 217 would correlate to cognitive function. It doesn't. It's either yes or no. We do see sometimes these people this will resolve. But it takes a while. It doesn't happen overnight, and there are lots of variables that impact, especially p-tau 217. But A beta ratios and p-tau 217 are two of these markers that help us understand if there's an amyloid process going on in the brain. So beta amyloid seems to be more correlated with cognitive function, but hold these loosely. They're helpful because they tell us about risk. So you can have someone with perfect cognitive function come into your office and be positive for beta amyloid and positive for p-tau. And I kind of put it in the category of ApoE status. It's like, this does not mean that you have Alzheimer's disease. Doesn't mean that it does mean you have Alzheimer's disease. It doesn't mean that you have Alzheimer's dementia. This does not mean you need to quit your job and put your affairs in order. It means we need to work harder to protect your brain health, your neuronal health. So this has created a lot of anxiety for people. These come back positive and they're like, I have Alzheimer's disease. Yes, and what we're picking up is what people have often heard, that you can detect Alzheimer's decades before you end up with symptoms. This is that detection, right? So we want to detect it. We want early detection because we can be more proactive about how we manage our brain health. So this is what we're looking for. This is a very typical beta amyloid ratio number that I would get in my office. It's positive. There is a neurodegenerative process that is amyloid driven going on in the brain. And so what does that mean? It means get the diet in order, get the exercise happening, get the sleep study, do the things that we know to do to protect brain health. I'm going to scroll down because I want to find the p-tau 217 just so that we can talk about how to interpret that. So this p-tau is flagged as high. 0.18 is the cutoff. And at 0.22, this is mildly elevated. I wouldn't be surprised if this patient did the work and came back a year later and this was under 0.18. That wouldn't shock me. It also might go up if they gain weight, if they lose weight. P-tau 217 is elevated in kids. Elevated p-tau 217 is associated with neuroplasticity. So when it's going up, that doesn't always mean that the patient is getting worse. So that's a really important thing to know, because patients will look at these numbers and be devastated if they go from 0.22 to 0.31. But they might have lost weight. They might be in a neuroplastic phase. So we want to, again, hold these loosely and not use them too much for directionality. I really, really hoped that they would correlate with cognitive function. So I was testing patients every 12 weeks, every 3 months. Now I test them once a year because this does not correlate to cognitive function. So I don't want to scare patients and have them think that it does. Okay, so that's p-tau 217. p-tau 181 used to be available. We don't run that anymore. It's not as good. p-tau 217, this is confusing. It has tau in it, and tau tangles are associated with Alzheimer's, but p-tau 217 is picking up amyloid. And so this is a surrogate marker for beta amyloid, for an amyloid PET scan. If it's positive, that's real. There is an amyloid process going on in the brain. But if it goes up and down in the positive, try not to think about that too much. If it's negative, there is not a significant amyloid process going on in the brain. So it is diagnostic for Alzheimer's disease, not Alzheimer's dementia. Hopefully that makes sense. Okay, so scrolling back up, we will find our HSCRP. This is a CRP. So CRP, we're looking at systemic inflammation. This is slightly elevated. I like to see this below 1 for both men and women, a little bit lower, even below zero point 0.5 for women. But this basically means there's some inflammatory process. Of course, our CRP is not specific. It could be because there's cancer, probably not at this level, but if it was at 25, maybe. It could be that they were fighting a cold. It could be that they sprained their ankle, or it could be a reflection of toxic or infectious burden in the system. So we want to do detective work. This is not diagnostic for anything other than inflammation, but it helps us understand, are we going in the right direction? Is this going towards zero or is it going up? What is the trend there? And if it's going up, maybe we need to dig deeper. Maybe we do need to get in those toxin and infectious labs. A CBC, these are things to, of course, pay attention to. We get patients who are anemic, right? That's going to be a nutrient deficiency, either B vitamins or iron deficiency. So we want to be aware of that. CoQ10 is, essential to mitochondrial function. So we want to be testing that. I would probably want to add a little bit of CoQ10 as ubiquinol, or as CoQ10 itself. So many people over 65 are on statins. And of course, we need to, if they're using an HMG-CoA reductase inhibitor, whether it's red yeast rice or a statin, we need to be supplementing with CoQ10. It is absolutely imperative for mitochondrial function and energy generation, right? Yes, for the cardiovascular system to pump the heart, pump that thumper, but also for the brain, right? The brain is such a resource-hungry organ. And if we're going to have enough energy, it's going to come from the mitochondria. And if we don't have CoQ10, that's going to be part of the rate limiting step. So we need to make sure there's enough of that on board. And testing it is one of the best ways to do that. On a CMP, I'm always looking at calcium. I've had enough patients over the course of my career who have elevated calcium levels that indicate a parathyroid adenoma, and it's an easy enough treatment where so many things, including cognitive decline, improve. And now there's cinacalcet, which is a medication that can help with calcium toxicity. There's also there's parathyroidectomies. You can take them out if that's indicated. But for an adult with a consistent calcium over 10, I'm screening for a parathyroid adenoma because it creates these nebulous multisystemic symptoms that are hard to pin down. And man, if that's what it is, it's a simple fix. So I just want to know that I'm always kind of keeping that in the back of my head and always really double clicking on that calcium level, particularly if it's over 10. And you can run a PTH. I think that we have that in here, a parathyroid hormone, although that's not always elevated because PTH only has a 15-minute half-life. So it's the consistent calcium that is the flag for me. Of course, we want glucose low, fasting glucose well under 100. I like it under 90 GFR. So we're looking at kidney function. Very common for an eGFR to be in the 70s. Creatine is a supplement that has great data for cognitive function. There was a small study, only 19 patients who were in it, but they had Alzheimer's disease, and with 20 grams of creatine, they improved cognitive function in like 4 weeks. It was very quick. It was really impressive. Creatine is very safe, but it will bump creatinine, and that will drop an eGFR. So you want to run a cystatin C as well, because this is not creatinine dependent. So you'll get a different number, and I would use this if you have a patient on a bunch of creatine for cognition. Look at a cystatin C and the eGFR calculated based on that, rather than using your CMP and your creatinine dependent eGFR. Now, if somebody has a low eGFR, high creatinine, high cystatin C, well over 1 on the cystatin C and the creatinine, well, go very slowly with the creatine, right? We're probably going to want to be reducing if their eGFR is under 60, I'm not going to give them 20 grams of creatine, let alone probably even 5. I might go slowly and watch their kidney function, but we want to be cautious about that, about adding too many amino acids and high doses if we have kidney issues. And then liver function, of course, if there's high toxic burden, all kinds of things happen that can have an impact on liver function. We want to be aware of that. And if there is ALT, AST, GGT is elevated, then think we have a GGT on here too. Then we want to be really focusing on the detox process. Maybe not. Um, so understanding liver function is an important piece, and this can give us some insight into that if we have elevated liver function tests. All right, cortisol. The best way to test cortisol is not through blood. It's much better through saliva, 4-point cortisol test. But sometimes you'll see grossly abnormal cortisol levels. Either they're bottomed out or they're really high. And that might just trigger us to do a salivary test or focus on the stress levels, right? So this is just a nice screening tool to understand, do we need to double down on kind of understanding the stress issues? Hormones. So hormones are part of the signaling process. If we think back to when we're 19, 20 years old, our hormones are peaking, and we don't have to go all the way back there, but they like 19, 20, 21, in that's when we're in college or we're learning a trade, we're meeting partners and friends, and we are socially engaged. We are engaged. Our brain is wired at that stage to make new connections. And part of what drives that is hormones, sex hormones. DHEA, estrogen, progesterone, pregnenolone, testosterone, all of those make a difference. So very typically, woman over 65 is going to be low in these. And so there was a paper published in May of 2025, I believe. Generally speaking, all of us in this space, we're aware that the conversation around menopause and hormone replacement has changed dramatically in the last couple of years. And it's so refreshing. It's so nice to see. Certainly in my clinical practice, when we start hormones, not for everyone, but for many women, it's like a wilted flower that just like perks back up. It's incredible. They sleep better, they have more sex, they're more engaged in things, they're happier, their skin looks nicer, their hair is thicker. There's of course aesthetic benefits to these, but primarily they just like come alive in a different way. So DHEA, precursor to testosterone. For men, I'm usually dosing 25 milligrams per day. It's fat soluble, so typically with food. For women, I'm pretty conservative, more like 5 milligrams a day. And for women, getting this number up towards 100, 150 is great. And that precursor to testosterone, we're going to get a little boost in energy typically. Dihydrotestosterone is the testosterone breakdown product. It's the metabolite of testosterone that's associated with male pattern balding, with acne, and aggression. So this is all the bad stuff associated with testosterone. And testosterone can become estrogen or DHT. There are all of our prostate herbs, our saw palmetto, those prostate herbs that we think of for help. This also, tied DHT will cause prostate hypertrophy and feed cancer. And so we want to keep this down for both men and women because it's not associated with the good stuff. And there's strategies to do that, including herbs. Estrogen, this is a very typical estradiol level for a woman who is postmenopausal and not on any hormone replacement. I'm typically using patches, always, always, always topical estrogen, patches or creams. I use Biest as a cream or a patch of estradiol. We can also use vaginal estrogen and dialing in the dose for what feels right for that woman. But usually wanting to get that between about 50 and 100 is typically our target. I don't have women cycle past menopause. We do consistent dosing of estrogen. Sometimes we'll pulse progesterone, but then of course you do need to worry about endometrial bleed or vaginal bleeding. And vaginal bleeding in a postmenopausal woman is endometrial cancer until you know otherwise. So I typically will use either oral or topical progesterone, and I want that number to be around. So this looks like a very typical postmenopausal progesterone level, well under 0.1, well under 1. And I want this number to be 3, 4, 5 in that range. So I'll use oral progesterone. 100 milligrams of oral progesterone is what you need to balance out the estrogen to protect the uterus. So if a woman has a uterus, she must have progesterone on board. So we want both of those to go up. And I dose 100 milligrams to 200 milligrams before bed each night. Can definitely help with sleep, can help people have much more restful sleep. And you can also do topical progesterone. Usually I'll do that with the biased for women who don't have issues with sleep. We'll just put it in the cream, put them together. It doesn't, of course, come with a patch. The patches come from retail pharmacies and they are only estrogen. So you have to do an oral progesterone or a progesterone cream. There are hormone experts out there who will do vaginal suppositories or rectal suppositories of progesterone as well. And some people feel that that's better. I think that the jury's sort of out. I see that oral progesterone helps women sleep better and helps with mood. If they tolerate it that way, it's practical, it's easy to remember. So I typically start there. So that's that signaling to the brain. Um, Iron, this is our nutrients, right? Too much, too little in the right place at the right time. High ferritin, quick thing to know about bringing ferritin down. Ferritin can be an acute phase reactant. So too much ferritin, not a great idea. It creates oxidative stress. Green tea will help to bring down ferritin. Just drinking green tea. So, and then iron. I'm not a huge fan of supplementing with iron because it can feed bugs, it can feed cancer. So what I typically do is have people eat some red meat, organic, grass-fed, good high quality red meat. FSH and LH, these are going to be high in a postmenopausal woman. It indicates that. I run them to keep an eye on them, but they're pretty much always high. And once you've run them once, you don't really need to. A1C, this is a little high, right? This is prediabetes. So a ketogenic diet is the number one thing to do here. There's herbs and there's metformin. There are other things that there's GLP-1s. For the right patient, that's worth discussing, but the ketogenic diet is going to help cognitively and it's going to solve this A1C very quickly. Homocysteine is a sign of methyl donor status, methylation status. So I use a combo product that has methyl B12, methylfolate, B6, and then some trimethylglycine. And that consistently gets this homocysteine down. Our target there is 7, right around 7. HSV, I mentioned, is one of the infections associated with amyloid production. We want to be using lysine as a prophylaxis every day. Powdered lysine can go with the creatine and coffee or tea in the morning. That's a great way to use it. We see these resolve over time. If somebody's having cold sores and outbreaks, get them your acyclovir, valcyclovir, get them on some pharmaceuticals for that. You need to treat really aggressively. And I always tell people, take this with you when you travel, take it to the dentist. Like if anything is going to stress you out, make sure you have this. Use it at the first sign of prodrome and then use lysine every day as prophylaxis. Insulin, this is part of that metabolic picture. We want fasting insulin under 10 is our goal. And ketogenic diet will do that. Lp(a), this is genetic. We do see that as we get hormones on board, fish oils on board, as we get exercise happening, as we do all the lifestyle things, Lp(a) will go down. If it's genetic, and since it's there genetically, it won't usually normalize. But I have seen people with Lp(a) of 200 go down to 100, right? They're not under 75, they're not under the cutoff, it's still getting flagged, but it improves significantly. So it's worth looking at. Lp(a)2, this is kind of known as a cardiovascular marker. It's associated with gum disease. If it's elevated, it's not only a cardiovascular risk, it is a cognitive risk. And 9 out of 10 times, it is something in the gums. It's cavitations, it's an old root canal that's still infected. There is some infection in the gums or the jaw. So if I see that elevated more than once, the other thing is you can ask patients, did you get a recent cleaning? What day was your last cleaning? Because it'll be elevated for the next few days after they get a cleaning at the dentist. So if you see that, it might just resolve and maybe have it retested. It's such an ordeal, especially if someone has never seen a biological dentist, never had a cone beam done. I usually wait for this to be elevated twice and then I send them. But I had a patient the other day, man, it's been elevated for years. And like, one of their good friends is a conventional dentist. They didn't want to go to biological dentist, but I was like, you must, because that number was just going up and up and up, the Lp(a)2. And again, It is creating cardiovascular risk and cognitive risk. Lipids, triglycerides are a direct reflection of carbohydrate intake. It can be a Snickers bar, it can be potatoes, it can be pasta, it can be cake. It is a direct reflection of carbohydrate intake. So that you will watch that triglyceride number go toward, I like it below 75 for my patients, and it will get there on a ketogenic diet. Most of these things will improve. Now, this total cholesterol at 145, that is going to be associated typically with depression, poor wound healing. So we want that number. I like that number between like 175 and 225. Unless somebody has active heart disease, active diabetes, I don't really want them that much lower than 200. And I don't mind if they're a little over 200, particularly if their LP little a is okay, those triglycerides are low, and their small density LDLs are not too high either. And maybe you're looking at a cardiac calcium score. If that's really high, then you want to be more aggressive. If it's zero, you have a little leeway. We don't have to suppress total cholesterol down below 150. p-tau we talked about, progesterone we talked about. This is a woman, but we would run a PSA, of course, on a man. We're looking to see if there's something concerning there. PTH is that parathyroid hormone that we're looking for. If that is elevated and the calcium is over 10, get a consult or send them out for an evaluation for parathyroid hormone, parathyroid adenoma, because that can cause cognitive impairment and it is solvable. T3, so TSH, this TSH at 3.2, ideally it's around 1 from a functional medicine perspective. So this patient may benefit from a little bit of thyroid replacement, at least some nutritional thyroid support. It is never the thyroid's fault. Some other stressor, some other nutrient imbalance, some other infection has pushed the thyroid out of balance. We want to help and support it. And there's multiple ways that we can do that depending on the patient. The sex hormone binding globulin is often elevated after women have been on birth control pills. And I don't always expect it to normalize. It can also be elevated with high stress. So we watch it, but there is Shilajit, there are some things that uncouple estrogen and testosterone from sex hormone binding globulin. So you can use that to help increase the bioavailable testosterone and estrogen. And then testosterone, I use quite a bit of testosterone in women. I tend to use 2 to 5 milligrams per gram, 1 to 2 clicks of that. So, a quarter to a half of a gram daily to start. And then I let women just decide what works for them. Some women love it, some women hate it. So testosterone, I tend to use quite a bit of testosterone for women. The dosing I do is 2 to 5 milligrams per gram, and then I'll use 1 to 2 clicks, an Atopi click or a quarter of a gram to a half a gram. And I let women, it's such a low dose, I let women just run with it. If that feels good for them, if it helps with muscle tone, with libido, with energy, with mood, I just let them go for it because they're not usually going to get too high, particularly because most of them start with below detectable levels of testosterone. Now, adding that DHEA like we saw above, that can help as well to just have more backbone for testosterone. And so some women love having more testosterone, some of them aren't into it, and that's okay. But men, I don't use a lot of testosterone replacement. What I usually use is something called N-clomiphene, which helps, it's like Clomid, it helps with testicular production of testosterone. Because if with male doses of testosterone, like 200 milligrams a week or 100 milligrams twice a week, those doses, you've got to manage. One, it's a controlled substance, so it's kind of a headache to get. But also, now we've got to watch for clots, we've got to look at CBCs, at liver function. They can, the acne, the aggression, the male pattern balding become an issue, the BPH can become an issue. So I like to use N-clomiphene instead of testosterone because for men, which is a little counterintuitive, I'm using testosterone for women, not as much for men, because I think there's something less risky that we can use that gets all those numbers up. If I see a man and his testosterone's at 220, 230, well, I want him up closer to 700, 800, but I don't need him at 1400, right? Where now I've got to manage all these other side effects. that just going from 2 to 300 up to 7 or 800 can make the impact that we're looking for on the signaling to the brain and on mood. And if they're losing weight because of the ketogenic diet, we want them putting on lean muscle. That's going to be a lot easier with some more testosterone on board. Thyroid antibodies, of course, part of that autoimmune process. There's whole books written on how to approach that. Getting thyroid hormone dialed is again, there's entire books and courses on that. Uric acid is something I'm looking at. I want that therapeutic target for my patients is under 5. So this is another inflammatory marker. And usually we see that come down with good diet, good exercise, good hydration. And then a nice UA, making sure I love seeing ketones in there. That's what we want to see, especially at the beginning of a ketogenic diet. We'll pick that up in urine. And then our B12 and folate, that is going to be downstream from this is going to be upstream from our homocysteine. I like to have folate up over 20, B12 up over 2000, so that we have enough of those nutrients, right? Not too little of these nutrients that are so crucial to detox, to energy, to metabolism, to so many different processes in the body. I will double click on this calcium oxalate. This can indicate that there's a risk for kidney stones. And also there's a lot of oxalates. As we go towards a ketogenic diet, a healthier diet, there's a lot of oxalates in almonds. So almond milk, almond butter, almond flour, almonds as a snack, spinach. And right, spinach goes in the smoothie, it goes in the frittata, it's on the salad, it's in the salad. And then chia seeds. All 3 of those foods are things that people tend to use quite a bit of on a ketogenic diet, and they're all very high in oxalates. But the way to address that, if we see calcium oxalates, that's a precursor to kidney stones, calcium oxalate stones, we just add potassium citrate, and that helps to keep that from precipitating. Or you can also do lemon juice. They can drink lemon juice, usually through a straw because it is acidic. And then vitamin D. Vitamin D, we want between 60 and 80, 60 and 90, excuse me. We want that to come up. That's going to help with brain function. And usually we use it with K2, D3, K2 for bones, for brain. It's a signaling hormone that helps, again, get us into that out of the attack and defend mode and into that rest, digest, heal, synaptic connection mode. So I think that takes us through everything. We have gone through our DHA Labs brain health panel, and I hope that you have some confidence now taking a patient through that and what you can do. So we'll take questions now. Hi there. Hopefully everyone can hear me. I see a few questions in the Q&A. So there's some fantastic questions. The first one from Joy, with chronic herpes titers, how to get ahead of that before issues arise? These viruses live forever in the nerves. So herbs, pharmaceuticals, supplements, frequency, therapy, other alternatives. Great question, Joy. So if that HSV1 titer is elevated, we add a gram of lysine every day. And I'm often having people logistically, it really helps to just have people put it into their coffee in the morning. So like I make matcha every morning, whatever you're doing already, it's so much easier to add this, right? The habit stacking, to add it to something that you're already doing. So if you have them doing creatine, which I think most people hopefully in the dementia and Alzheimer's space are doing some creatine, at least 5 grams, add a gram of lysine as well. We see, because we test serial HSV markers and HSV1 markers, and we see that people doing a gram of lysine a day, they will get those titers down. We will see them resolve. So that's nice to see. The other thing is you can use pharmaceuticals on the spectrum of people with positive HSV1, right? Some people have titers that are elevated, which can have an impact on an amyloid response, right? So we do want to get those titers down, even if they aren't having active cold sores. But if somebody does have cold sores, then we want to probably be a little more progressive. So aggressive, not just progressive, excuse me, aggressive. We can use our acyclovir, valcyclovir. And I have colleagues in the Bredesen space who, MDs who are much more comfortable using those. and they'll do a like 1 week per one out of every 4 weeks. So 1 week a month, they'll do prophylactic acyclovir or valcyclovir. I tend to use it for people who do get outbreaks. I'll have them fill acyclovir or valcyclovir. A lot of people will tell me like, oh yeah, I've used Valtrex for years. I'd rather use that one. Totally fine. I'm not attached which one, but I tell them, carry this with you. Never leave home without it. Take it on every single trip because when they're stressed and jet lagged or doing something, they'll have that prodrome and those work best. You can use less of them if you're really aggressive about treating at the first sign of prodrome. You can also triple the lysine, right? You can go up to 3 grams of lysine. You can divide the doses over the course of the day. I'm also a fan of a product called H2plex, which is made by Priority One. It's got some lemon balm and some lithium actually in it. Lithium can be helpful. Lithium orotate, not lithium carbonate, not bipolar doses of lithium, but lithium orotate, which is great for memory too, but also antiviral. So the H2plex is something that you can use. Lysine every day prophylactically is something you can use. And then, of course, I do recommend the pharmaceuticals just because the benefit outweighs the risk. Now, the risk there, and I've seen some MDs will put people on prophylactic acyclovir, valcyclovir all the time for recurrent outbreaks. And then you just have kidney risk, kidney and liver risk. So I think primarily kidney risk. So I try to avoid that. But absolutely, aggressive treatment of outbreaks reduces your risk of dementia. Have I ever considered transdermal DHEA versus oral? Yeah, and certainly like vaginal DHEA we use with estrogen sometimes. Yes, we can. I think that's just like patient preference, cost kind of determination around what makes the most sense there. But yeah, transdermal DHEA is can be great. Happy to use that. And then, is there a DHA lab package available to practitioners with the test combination Dr. Sandison reviewed today? Yes, absolutely. And I am sure if you signed up for this webinar, you will get a link to that package. It's the one that I just reviewed in this webinar. Shouldn't we be measuring the active D levels versus storage of D? That's a great question. And I think, even with B12, right? It's like, shouldn't we be looking at methylmalonic acid? It's cost benefit, right? So if the cost of the lab test is exponentially more than what the simple one, then what we're looking for like, do we have enough, right? That's the question. And then trying to keep the cost of all of this as low as reasonably possible. I think that's what's come up for me, Joy, in terms of the different types of D to measure, or even like measuring MMA versus B12. When it's cheap and easy, I mean, even when you talk about like hormones, salivary hormones or urine hormones versus blood levels of hormones, it's like I can do my job with the blood levels of hormones that are going to be covered by insurance and easy to get. And so there are certainly there's a time and place for some of the more, expensive lab testing. However, I want to be measuring these things every 3 to 6 months on my patients and getting them to that spot where they need to be to optimize. And with vitamin D, I think I can do that with less expensive testing. Are there long-term issues in terms? Oh, there was a question that I think got answered in writing. From Sarah, what are the issues with long-term use of keto? So, Sarah, I apologize if I did not say this, but I do not think anyone should use keto long term. Right, so we want to bounce in and out of ketosis, and that usually happens naturally. It's very challenging for someone to stay in ketosis forever, right? Because you get on a plane and there's nothing at the airport to eat. So you grab something on the way and it has some sugar in it and your blood sugar goes up. Or there's a wedding or there's a trip or there's something, you have people over, you go to someone's house. It's very challenging to stay in ketosis forever, right? Because life happens. Now, I think that all of us, like you probably have the same long-term risks associated with long-term always being in glycolysis, right? All of our lives. Our bodies are designed for that metabolic flexibility to go back and forth. And if you aim for ketosis, usually you're going to end up being in ketosis some of the time, not all of the time. So, but what we've seen is that mild ketosis you can sustain. There isn't a study that says this, But I think that over time, what we will see is that going back and forth between plant-based and ketosis is what's best for the brain. Because we see from the Ornish trial and from some other studies that a plant-based diet is great for cognition. Now, in a multimodal, multiple variables are in that intervention, right? In the Ornish trial, there was support group, there was meditation, there was exercise, there were supplements. So it wasn't just the diet. We see the biggest delta in cognitive changes getting that ketone level up. So I do think that anyone working with me, I want them to get into ketosis at least once, unless they have like eating disorders, I would say are the biggest contraindication. If I'm going to trigger a disordered eating pattern, then I want to stay away from it. But even with hyperlipidemia, with gallstones, with lots of things that I think people consider a caution or contraindication around keto, it actually can be helpful. So I think that there's more risk in staying in glycolysis your entire life than there is in staying in ketosis long term. And also, I don't ever think that anybody should stay in ketosis forever. You can flex back and forth. How much potassium citrate would I use for high oxalates? So when, again, have that dietary conversation with them, probably back off. You don't have to eliminate almonds, chia, and spinach, but just make sure they're getting other nuts, like use macadamia nut milk or, if munch on like what walnuts and pecans instead of almonds. Maybe use something other than almond flour. It just mix it up. And then I use it's potassium for whatever reason comes in 99 milligrams. Sometimes you'll see 100, but usually they're in 99 milligram capsules. And I just use one a day. And that tends to help bring the calcium oxalate stones down. You can also, there's a ton of herbs too for breaking up, but like there's a stone breaker from Herb Farm. There are herbs that can help with that as well. But potassium citrate is an easy way. And then getting the dietary changes in. Um, Besides HSV1, are there other important viruses or bacteria that we typically test for cognitive challenges? Yes, good question. So there's a handful. So HSV1 is an important one. P. gingivalis and the LPPLA2, which was on the test, that can give us an indication of not just P. gingivalis, but there are several bacteria, oral bacteria, that can drive neuroinflammation. So we do sometimes run immunoglobulin testing for Porphyria gingivalis, but there's others out there too. So I think the LPPLA2, it's an indicator of that potential viral or bacterial burden in the mouth. And then there are also um, there's evidence that Lyme spirochetes, so particularly Borrelia, but Babesia and Bartonella can also have an impact on cognition. So I've for a long time referred out, although I work with Steve Harris and Bob Mosiani and share patients with them, and so feel relatively well versed in supporting someone with Lyme with help. But screening for that and then potentially referring out. I had a patient this morning who, well, actually a coaching client, and it was his wife kind of telling the story, but they really feel like treating Lyme had a big impact on his recovery. He's doing much, much better than he was 2 years ago. He, in fact, took on this big project of like repairing their porch and putting in a new sliding glass door. He had 3 contractors over to bid it, and like he couldn't even empty the dishwasher and put things away in their kitchen that they've been in for 40 years. 2 years ago. So really big recovery. And it was because of treating Borrelia. So I never want to, it's hard, right? Like that's a whole world in and of itself, ILADs and everything that happens in the Lyme world. But it is something to at least screen for with cognitive patients. Then COVID is another one. COVID is a different mechanism. And I was talking to Dr. Redison actually earlier today, and he keeps talking about how he's expecting that there will be more of a dementia called late. This is a different, obviously different from Alzheimer's disease, which is an amyloidopathy. Late is a TDP-43 which ALS and frontotemporal dementia are in that category. And it seems to be triggered by viruses. So late is a type of dementia that happens to people usually in their 80s and 90s, and it actually is much slower progressing than Alzheimer's dementia. Anyways, I'm on a tangent. Sorry, you guys. COVID does cause like issues with microcirculation, right? Like clots in the microvasculature. And so usually with that can, and obviously in the brain, that can have an impact on cognition, but we're thinking about it a little bit differently. It's not from the virus itself, it's the clots that are formed from that cytokine storm. And so we're thinking about things like nattokinase and serrapeptidase and maybe Neo40 or like that Calroy product, what's it called? Somebody hopefully here knows and can put it in the chat. But um, I can't believe I'm blanking on the name. I need my own medicine. Anyways, the anything that helps with supporting blood flow is what we want to think of in terms of COVID and how that as a virus affects cognitive changes. From Jody, how important is it to balance taking 200 milligrams of progesterone with an estrogen patch? I've been taking progesterone at age 60 for sleep assistance, but could it cause an imbalance? Should it be more DHEA patch and progesterone mix? Yeah, great question, Jody. So, there are different perspectives on this, and I wouldn't say that I'm a hormone expert, but I was trained by Tori Hudson. Also learned a lot from my doctor dad, Dr. Drucker, who I worked with for a few years after getting out of school, and he's an MD who did the bioidentical hormones through A4M. And so, 200 milligrams of progesterone should help with sleep. What we see in the literature is that it's the estrogen that's most important for your brain. And so, but you need to get enough progesterone to balance out the estrogen so that you don't end up with endometrial cancer. And the dose there is 100 milligrams of oral progesterone. So you don't have to be up at 200. But you want to be thinking through all of your sex hormones, progesterone, estrogen, DHEA, pregnenolone, testosterone. It's not just about balancing one or even just estrogen with progesterone, which needs to happen to protect the uterus. However, for brain health and supportive brain health, it is good to get all of those markers and then optimize each of them. And so it might mean that you want a little DHEA. With the patch, what we understand about progesterone is that 100 milligrams should protect you. 100 milligrams daily of progesterone should protect you. And then it really doesn't matter what the patch dose is. And for women over 65, the sooner you start hormone replacement, the bigger the reduction in risk. But there's a Finnish study of 500,000 women and some of them were initiating hormone replacement in their 70s, 60s, and 70s, and they were still getting risk reduction. So don't be afraid. In my opinion, don't be afraid, especially if you have patients who are struggling cognitively. Do not be afraid to initiate in your 60s or 70s. But the sooner you initiate, the better. Then for patients with ApoE44, besides optimizing behavior, are there other things like supplements that can be protective long term? Absolutely. Yeah. Yeah, definitely. I think I think my point in the ApoE44 story of like why people should look early, man, alcohol makes such a big difference for people who are ApoE44 positive. They get a lot more damage to their brain than the rest of us who are not ApoE44 positive. So that 2% of people, they should get on the AF bandwagon, right? Like they definitely should be avoiding alcohol because it's just so much more damaging. And they need to be really good about glutathione. But yeah, the supplements like creatine, like lithium, like omegas, optimizing vitamin D, those are things that they could be doing if they take the invitation that they could be doing um, early on to protect their brain health, certainly. From Kathy, for people with chronic mold exposure, for example, a mold expector or a mold remediator, would you recommend binders long term or other protective measures that they might be able to adopt? Yeah, yeah. And I would say even like testing, right? I mean, I get my mold tested once a year because I stay places, and what if something happens and there's a leak in my house? Yeah, I think testing and then using binders, you can certainly get on some sort of, you know, maintenance plan where you're not necessarily taking the highest doses, but you're taking something like a little GI detox every day, glutathione every day, versus, if you were on an aggressive protocol because of an exposure, you might be taking two and three. Maybe you're taking two GI detox twice a day, plus some cholestyramine, plus, some liver support. You might have a maintenance kind of plan. That would make sense to me, Kathy. From Joy, what are the interventions for high P. gingivalis? Um, I would send someone to a biological dentist. So, of course, there's the water pick and brushing and flossing and a good toothpaste, all of those things. It's the dental hygiene. But I would send them off to a biological dentist to get that really cleaned out and getting yeah, get them dialed. Have I heard of helmet therapy for ApoE44? And do I have thoughts on this? I heard of helmet therapy because of MAPS and autism. I have not heard about it for ApoE44, so I just can't even comment. What about using progesterone for a patient with no uterus for mood and sleep? So, Lynn, I do think that that's worth using. You don't have to. And what we see is that most of the benefit comes from estrogen. So if that patient gets into a place where their mood and sleep is dialed with things other than progesterone, you're fine to take her off. Yeah. Um, I think that there might even be an argument to do that. Would I recommend an omega-3 index? Yeah, I like those. Yeah, and I think I like getting those numbers up on the omegas. Wonderful. I think that's all the questions. I hope this has been helpful. It's been a real privilege to be here. Thank you so much.